here for the webinar of the Love Avon Army of Women. Also, happy Black History Month. And in honor of Black History Month, we're going to talk about one of the research studies we've recruited for, which is really looking at the experience of, particularly of African American women with breast cancer. We're very honored today to have Dr. Vanessa Sheppard. She's a cancer control scientist and assistant professor in the Department of Oncology at Georgetown, and she's also a National Institute of Health Disparities Scholar. Her real goal and the focus of her research is looking at the differences and increased burden of having cancer by minority women. So she works on African American women, African immigrant and Latina populations, and this particular study was focused on looking at the factors that contribute to different experiences and trying to get a handle on what they actually are. So really following and tracking and looking at women's experience as they're diagnosed with breast cancer in order to get a better understanding about the barriers and the motivators for women and how to better do it for African American women. We're going to have the presentation with Dr. Sheppard. I may break in every now and again if something sounds over my head. And then we ask you to submit your questions, and you can submit them as they occur to you, because if you're like me, you'll forget them by the end of the presentation. And then we will, at the end of the presentation, we'll be asking Dr. Sheppard and get all your questions answered. So with no further ado, I'm going to hand this over to Dr. Sheppard and thank her for joining us at the Love Avon Army of Women webinar for her presentation, Narrowing the Gaps in Breast Cancer Adjuvant Therapy, Recruitment, Collaboration with the Army of Women, a program of the Dr. Susan Love Research Foundation. Okay, Vanessa, it's all yours.
Oh, thank you so much. Good morning and happy Valentine's Day. I'm very excited to be here to have this opportunity to share our experience of collaborating with the Army. We met at a very critical time during our research protocol, and our study has benefited tremendously. So in terms of the outline of the presentation, I'd like to give you a brief background about the GAP study protocol and specifically talk about the recruitment collaboration and also share some preliminary findings. So what was the purpose of this study? We refer to the study as the GAP study. And so what we were really interested in was to examine the factors that predict the initiation and the completion of adjuvant systemic therapy in Black breast cancer patients. And we were interested to know if the predictors would be the same or different for white patients. The underlying purpose of the overall goal was so that we could learn information that would help us to test potential explanations for the disparities and also then to identify opportunities where we could intervene with the goal of reducing or eliminating the disparities in adjuvant treatment. So why should we study treatment gaps? Primarily because differences in breast cancer outcomes have been reported by race. African American women in particular have the highest breast cancer mortality of all other racial ethnic groups. And the comparisons for where we have data most often are with white women, and the disparity between Black and white women has persisted, and in some instances it's even widened after available treatment and technologies have come on the scene. The reasons for these disparities are very complex, and there are many factors that we know contribute to it. However, we know that it's beyond the clinical presentation and clinical factors. Systemic therapy, chemotherapy, and hormonal therapy are known treatments that do improve outcomes. They reduce the risk of recurrence, and they also reduce the risk of mortality. And studies have shown us that these therapies are, in fact, as effective in Black breast cancer patients as they are in white breast cancer patients. And so we thought that optimal treatment may reduce some of the disparities that we've seen. And this is because a few studies have shown that when breast cancer patients receive equal treatment, then the outcomes are equal. Disparities have been reported in the uptake of chemotherapy and hormonal therapy. African American women have been shown to have fewer consultations with oncologists, to have lower initiation, and perhaps even more delays to treatment. On the other hand, there have been very few explanations in terms of why some of these disparities exist. Why are Black women less likely to initiate therapy. And most studies have generally relied on information that's collected in databases rather than getting reports from patients themselves. And so what we wanted to do was to have enough African American women in the study to be able to look within African American women and also make comparisons with white women. So what did we do? This is considered an observational study. We didn't have any type of...
Before you start, let me ask you two quick questions.
Sure.
Initiation, you mean beginning chemotherapy? Is that what you mean, beginning treatment?
Absolutely, absolutely. And so...
Okay.
In this,
okay, now you go on. Sorry.
Okay. So what I will say in this study, we're looking at the whole spectrum of initiation and completion of therapy. But today I'm just going to talk about did women initiate therapy and how long did it take them to initiate therapy, and specifically chemotherapy. And so we recruited women from 2006 to 2011. And initially we were focused on hospitals in the Washington, D.C. area, eventually expanded to a hospital in Detroit, and happily collaborated with the Army of Women. The sample includes African American or white American women that had invasive non-metastatic breast cancer. Breast cancer had to be the primary diagnosis, and so women that may have had a recurrence were excluded from the study. Women also needed to be English-speaking. In terms of the data collection, we collected data via telephone survey and then also review of medical records. The challenge was to recruit 400 newly diagnosed women. And I'll just pause to say that we had funding from the American Cancer Society initially, and this was part of a career development award, and so very limited scope of funding. So the challenge was to recruit 400 newly diagnosed women. Could we identify them? Because we were looking at factors that would predict initiation, we needed to recruit women ideally before they started their adjuvant therapy. The next challenge.
So when you're saying initiation, you mean starting. Starting the chemotherapy. You don't mean starting the whole process. So they're already diagnosed.
No. So they're already.
And they've had surgery, I gather.
Yes.
But they haven't started whether they need chemo or hormones or something like that.
Exactly.
Okay.
Exactly. So that was a challenge, and because some of the factors that, or the measures that we were included on our survey related to the attitudes about treatment, cultural beliefs, their treatment experience, their rating of the process of care. So we really wanted to look at these factors and kind of where women were after receiving their diagnosis and surgery and how these things may predict then and distinguish who initiates and who doesn't.
And how the doctor both treated them as well that was explaining it and dealing with it.
Absolutely. And so we did. Women talked about their rating of the quality of care, financial barriers, the communication with their provider, their trust in their provider, and some of the sociocultural factors related to levels of spirituality, their beliefs about treatment. Did women have discriminatory experiences, as well as their marital status or living arrangements, rather, partner status, and employment status. And so, in trying to meet this challenge, I soon found that it's not that easy to recruit and identify women really in that short time interval. And we needed to expand how we were recruiting women and partner. And so after hearing about the Army in, I think it was Arizona, right before, then it was an opportunity for me to say, how could I benefit from this wonderful opportunity to recruit women? And I will just pause and say that some of my colleagues at the time said, well, you need patience. How are you going to get patients? You need to be connected with a hospital to get patients. And so, as you'll see, that they weren't right. And so I'll tell you a little bit about the recruitment process. And so we had institutional review board approval, and that is where a group of individuals make sure that the study has proper protections for confidentiality for patients, And so we had this approval at Georgetown, and then we also went through IRB approval with the Army of Women. Once we had that approval, then an email blast, and I love that term, blast, was sent to Army of Women volunteers. And the staff at the Army of Women reviewed the responses and compiled the contact information. On the other hand, our staff at the GAP offices, once we got that information, we contacted volunteers by phone. Women that were eligible provided verbal consent that they would participate in the study. We did the telephone survey. We mailed women consent forms. All of the participants sent those consent forms back to us. They received just a $25 American Express gift check thanking them. And then 6 to 8 months later after the interview, we then sought to retrieve their medical records after already having their permission. And so the recruitment results, within 2 weeks of the blast, which is why I like that term, 116 volunteers responded. And that was a short amount of time to reach a lot of women.
And what was your previous experience? How many did you have before that?
Oh, my goodness. We were happy if we had 2 patients a week.
Okay.
Yeah, I mean, really, when I said earlier that it was a critical time, being at this award was a career development award, I did seek additional funding from the Coleman Foundation to help cover the research, because basically career awards primarily just cover the cost of me as an investigator to get further training. And so having to have subcontracts with different hospitals is quite expensive. And then to do that and still only yield about 2 people per week, yep. I felt like my career was going to pass me by. And so this was, I mean, it just infused so much energy in terms of the process and the excitement, even with our staff in, getting the emails and contacting women. It was a wonderful energy that was infused into our project. And so 230 women were recruited as a result of these efforts. And we did not see any differences in the demographic characteristics between the Army of Women volunteers and other participants. And the reason why this is important, because there's a perception that individuals who may self-identify themselves to volunteer to be a part of studies may be so different from the quote-unquote average research participant. And so we didn't find that, which we were happy to learn. And then, we were able to also retrieve medical records, even though people were spread all across the country. And so where did the volunteers live? As you can see, really women were from all across the U.S. And as happy as I was to have women included in the study, I did wonder about the practicalities of will we retrieve and be able to get medical records. And so this has been a great experience. And so I will share some of the characteristics of the Army of Women study participants. And what's interesting here really is that when you look at the black and white women, there really aren't differences across the characteristics of age, stage, the type of surgery, education, and employment. And so in studies, you generally are very interested to see, are you comparing highly educated black women with less educated white women, or the reverse. And so what we see from the Army of Women study participants is that they were very similar, even in terms of insurance.
And that's what you want, so that you can see.
And that's what you want.
Yeah, you want to be able to see, you want to have the only difference be race.
Exactly.
Right.
Exactly. And that's right. And that's often hard. I mean, a lot of times in studies, you really have so few ethnic minorities that the proportion is so uneven. You can have a very large sample, but if less than 100 or if it's only 5%, which is pretty much often the standard in a lot of studies, are racial ethnic minorities, you can't really tell much. You don't really have the variability. And so
right.
This is important. So the next slide, the sort of study schema, the main point here really was to just point out that, we had to contact a lot of women that could be potentially eligible, and 33% of the potentially eligible women were from the Army of Women, and that's substantial because again, we were recruiting heavily here in the D.C. area. We were trying to hit support groups as well as hospitals, and yet 33% came from the Army of Women. And so the next few slides are going to summarize some of the characteristics and what we're learning from the GAP sample as a whole. And so while we had over 400 women are in the study overall, I'm focused now on the 369 for whom we have their complete medical records that have been analyzed. And so as you can see, the average age of participants was right around 54, 55. 59% of the sample was black, and we say hooray to that because you don't really see studies that have this large representation of African American women. The majority of the women had greater than high school education, and about half were either married or living as married, highly insured by private insurance, and this is also reflective of women in the D.C. area, actually, and about half received their treatment at NCI cancer centers. And so some of the clinical characteristics, the majority of women were between stage 1 and stage 2 at diagnosis. 76% had estrogen receptor positive breast cancer. Interestingly, when we compared black and white women in the study on these different tumor characteristics, nodes, and such, there weren't any racial differences in the these disease factors, or even in the type of surgery. Where we did see differences between black and white women were in terms of comorbidities, such as hypertension, and as you can see,
other things they might have.
Other things they may have.
I'm just translating comorbidities.
Thank you. Thank you. Absolutely. So beyond breast cancer, looking at some conditions that women may have had at diagnosis. And so what we see is that in the orange bar represents the black women in the study, and the green represents the white women in the study, is that black women had higher rates of hypertension, of diabetes, and also obesity. And we're concerned about that because we know that after women then survive breast cancer, these other conditions can also be problematic, and we want breast cancer patients, all breast cancer patients, to be as healthy as possible. And then they were more likely to have one, greater than one comorbidity. So in addition to breast cancer, black women were more likely to have some other problem, health condition, than white women. So now let's kind of turn to looking at what are the factors that influence chemotherapy initiation. And so I've sort of divided the factors that were important into different groups. And so first, what we see are clinical factors. And so women that were had hormonal receptor negative status, they had higher odds of initiating therapy. And so the 2.8 is comparing women who were HR negative versus those that were HR positive. And so this is something that we would expect. So this is
right, because you're not going to treat the hormone negative people with hormones. You need to treat them with chemo. So
absolutely.
That would be expected.
Absolutely.
And higher
so that's a good finding.
Yeah, it means they were almost 3 times more likely to be on chemo than the hormone positive people, which is how it should be.
Exactly. This is how it should be. And so similarly with women that had positive nodes, were twice as likely to have a higher odds of initiation. And we also saw the same sort of trend, so the greater the tumor size, then the higher odds of initiation. So we would expect that these clinical factors would be in this direction, and so that's what we would expect, and that's good. When we look at age, what we found was that women that were under the age of 50 had a 2-point higher odds of initiation. Now, what I should mention is that we looked at each of these factors individually, and then we looked at these factors concurrently. So we put them all in the same statistical model. So age is actually, when we find the effect of age, we are taking it into account the clinical characteristics. So regardless
so even apart from, because young women are more likely to be hormone negative.
Exactly.
You're saying that this is apart from that.
Exactly. Exactly.
Okay.
Exactly. So, so that's something interesting, and that's not something that we can say that that's good or it's bad, but it's a difference there that we need to understand more. When we look at treatment attitudes, what we found, and so we asked women basically in terms of how they would weigh the benefits, how they saw the benefits and the risks of therapy. And so the benefits, in terms of an example, would be believing that if they had chemotherapy, then they would be less likely to have a recurrence or have the disease come back. A negative could be the side effects, because they were more concerned about side effects. And so the balance between the perceptions of the benefits and the risks, that's what we measured in regard to treatment attitudes. And so we had a scale, and what we found was that women who had more positive views about chemotherapy were 3 times more likely to initiate therapy than women who had more negative views of chemotherapy.
Which also makes sense. If you really think it's going to work, you're more likely to do it than if you're really worried about the side effects and don't think it's going to work.
Absolutely, absolutely. And so what we think, and we'll talk about kind of what we think this means later, but this sort of gets at, this is something that we can modify. You know, a person's age, you can't really do much about that in terms of, you can make suggestions in terms of the interactions with their provider, but in terms of women's understanding of how the particular treatment is going to benefit them, we can do something about that. So then we went on and we looked at communication, and so we found that communication actually was significant, but it was only significant in Black women. And so,
what do you mean by communication?
And so with communication, women rated their amount of involvement in asking questions and the amount of information that they got from their provider. Did they get adequate information? Did they understand that their doctor explained the risk and the benefits of treatment? And so trying to get at, was good information shared between the patient and the provider? And so women that rated that they had good communication, in terms of Black women with good communication were 4 times more likely to initiate therapy compared to Black women that had lower ratings of communication. But in white women, communication wasn't significant at all. In fact, it was in the opposite direction, suggesting that more communication was less initiation. So this is what we would call
Maybe they felt like they were being sold a bill of goods.
maybe so. And so what this sort of suggests is that, well, 2 things. One is that we would say this is an interaction effect. So while we saw a lower initiation in Black women overall, that effect was modified by communication. So it was communication and race together versus race only that influenced initiation. And so that's something, again, we think where we can have modifications. So the other outcome that we looked at in regards to initiation was the timing of chemotherapy initiation. So this slide is basically describing the days to initiation. And so what we found, and the bottom sort of chart just sort of breaks up in weeks, sort of clumping it together. But what we see across the spectrum is that Black women had a longer delay. And so on average for Black women, it was about 73 days from their definitive surgery to starting chemotherapy. And for whites, it was around, white women around 55 days on average. And so the 3 factors that we found sort of independently that were predicting initiation delay, we then put in the model together to try to control for these factors and then treatment and clinical factors. And so there was a greater delay in Black women that was significant. Whether or not you were living with your partner or not influenced delay, such that women that were not currently living with a partner had a greater delay. Because
they didn't have anybody to nag them.
That's right. That's the
into getting in and getting started.
Exactly, exactly, And at first we were thinking, well, if somebody's partner, we expected it could be in the opposite direction. Maybe they have lots of things to take care of. But when we had this finding, we really thought about it. And it's exactly, it's that support in getting to treatment and getting things, moving along. And then we found that trust in the oncologist was associated with delay. And so when trust was greater, delay was less. And in fact,
also, if you don't trust your oncologist, you're more likely to think to have a little bit.
Exactly. In the model where we had all the variables in together, what we saw is that the race effect went down once we controlled for distrust in oncologists. So what did we learn? All right. So what we learned was that recruitment through the Army of Women is fast. I can't think of any way that we could recruit women more quickly or identify potentially eligible women, unless I was sitting in clinic myself and every woman that came in, I was able to recruit them, but we know that that wouldn't work. That it was feasible to do. It was easy to do. The process was easy. Women were willing. We were able to, once we had consent, to get medical records to us by mail. In most instances, there was no cost associated with it. If there was a cost, then we would take care of that for the participant, and it works. And so in terms of other researchers, I think the lesson for me and for others would be that you can recruit outside of your geographic area.
Right.
So we're not limited just to D.C. We're not limited to where I can drive. I'm not limited to finding a collaborator in a specific state. You can go anywhere. And you can recruit, and you can recruit newly diagnosed patients. And that was where people were like, oh, you're not going to be able to recruit newly diagnosed patients. You can barely get them within that time interval locally. But we were able to do that. And you also could include a diverse group of participants, And so these were important lessons for us in terms of being able to do this. And so what did we learn in terms of initiation of chemotherapy? The first thing is that it's important to make comparisons within racial and ethnic groups. We say this, but generally we're not able to do it because we usually have a small sample of African American women or other ethnic groups. And so when we looked within group, we saw that certain factors were different factors predicted initiation based on one's race or ethnicity. And we did identify some factors beyond clinical characteristics that were important. That gives us, we think, several opportunities for interventions, interventions that focus on just generally strengthening that relationship between patients and their providers, specifically communication, and communication in Black women. I mean, I think communication is good for everyone, but we specifically saw that it made a difference in Black women that were diagnosed with breast cancer. Everyone's attitudes about therapy. We feel like women should have enough information so they can understand the risks and benefits for their particular treatment. And that if relationships with providers are stronger, this may be one way to reduce disparities. And so certainly healthcare that people receive is important. We know that, but we think that what we're finding supports it with quote-unquote sort of empirical data. And this is a statement from one of the volunteers, and she writes that, or says, I think that the hospital makes a difference in the quality of care you receive. I travel past my local hospital to go to a better hospital. You don't feel like you're sick when you're there. And so
I have a couple of questions, and I also want to say to our audience, this is your time. Put in your questions as we're coming towards the end. One question I have is whether you looked at all at whether the treatments they got were appropriate, because you had their medical records, so you could compare them to, say, national guidelines, because you wonder whether there's a racial disparity in whether people are getting chemotherapy appropriately.
Right. And so what we've started to do, and so we looked at, among this group, we created another variable where we stratified the data in terms of whether guidelines would say it's definitely indicated or considered. And so all of the women in the study sort of fell into one of those two groups. And so overall, the rate of chemotherapy initiation was right at 38%. And so we did see a higher initiation of chemotherapy among women for whom it was indicated, and that was right at 50%.
Right.
So
okay.
even among the group for whom the guidelines say you should have it, that the guidelines, it was only 50%. So it's still less than optimal.
Okay. Okay. My other question is, and then we've got a lot of questions coming in, which is great.
Okay.
My other question is whether sometimes, being a doctor myself, I know that changing a doctor's communication style is so impossible. So you wonder, did you ask or did you know whether they had patient navigators or anybody else helping with the communication?
We did not. And that's something that we think there are some places, hospitals that had navigators. But we don't know for each specific person, So we have thought about to try to control or to take into account if the hospital had a navigator or not. But that's
because it may be that communication, regardless whether it's patient provider or patient nurse or patient, navigator. In other words, the important thing may be having somebody actually sit down and spend some time explaining to you the pros and cons, regardless of who it is.
Absolutely, absolutely. So one of the things that we did do, we did measure sort of communication, overall communication with a nurse and the surgeon. So we got the surgeon, the nurse, and the oncologist. And so we did do that, but for the women, and it would make sense, I guess, that had the chemotherapy, the conversations with the oncologist were key. For Black women, again, this wasn't for everybody.
Right.
Yeah, this is for the Blacks.
All right, let's get to some questions. So the first one, Marla asks, and I can actually help answer this. Are NCI centers assumed to be a higher standard of care? You would think that National Cancer Institute centers would be a higher standard of care, but in fact, the National Cancer Institute center just means that they do research. It actually doesn't, the National Cancer Institute does not look at the standard of care. So it's a little bit confusing, but it's based on their research, on the fact that they have a strong research program. Now, you could argue whether having, being interested in doing research means you also have a higher standard of care, and that may well be true, but it doesn't necessarily guarantee a higher standard of care.
Exactly.
Now, for you, Vanessa, was there a correlation between communication and positive attitudes? This is from Linda.
And so we have started sort of a sub-analysis, and we do see a relationship between that in terms of treatment. And that would make sense because the communication questions sort of get at their communication about the risk and benefits. And yes, there was a correlation between the rating of communication and a woman's attitudes about treatment. And it was in the direction where higher communication, more a positive view of therapy. That's a great question.
Okay. Sarah, here we go. Sarah Williams was asking which N is correct, 230 or 369. Both numbers were mentioned.
Right. So the 230 was the total number of women that responded from the Avon Army of Women. The 369. So the 369 number is the total number of women in the study for whom we had medical records. So let me see. So going back to the slide of the schema. We identified potentially eligible women at 744. And then we sort of went through the process of who was actually eligible, and then some women declined, weren't ineligible, and then the bottom end of 369, those are the women that we have completed medical records.
Got it.
And then we did a total of 448 interviews. Yes.
Okay. Will you follow this group? This is from Nancy Ryan. Will you follow this group over time to see what their long-term treatment outcomes are, time to progression, survival?
I'm very interested in doing that, and I want to do that, and I'm trying to put together a grant to do that because in terms of research, I'm at an NCI research institute, and what we do is research. And so to do something like that, then we have to have additional funding. So I'm in the process now of seeking additional funding.
Great.
Particularly given some of the other conditions that women had at diagnosis, to really look at some of those things may impact.
Okay, here's another one. It's from Dr. Woodruff. If not already discussed, was there any behavioral lifestyle data collected for these participants? If so, how did it correlate to initiation?
Oh, I'd like to bang my head on the table right now. Because we did not. We did get height and weight to be able to calculate and compute BMI, but we did not get other lifestyle data. The medical records capture of smoking and some other things is really sketchy, and so it's just most of it is missing. And so we're trying to look at that to see, is there a subset of women for whom those data seem reasonable? But I really wish I had done that, particularly since I am now doing a study that's focused on physical activity in African American women that I will say was prompted by the high rates of obesity and being overweight in this study. Yeah, but I wish.
Here's another one. This is from Deborah Lakshu. A communication is a two-way street, and it's hard to know if poor communication is due to provider characteristics, patient characteristics, particularly lack of trust, or shared responsibility. Do you have any way to assess or control for that? It seems like if we knew more about why communication was poor, we'd be able to do something about it. Maybe that's the next study.
That is the next study, but it will be the next sort of analysis. So first, sort of after looking at what factors then sort of predicted the initiation, and of those factors that we see are important, we are going to then look at what factors then predict, factors in our study that predict communication. And so we have limited information about the providers, but we have their gender, ethnicity, and provider type. And then we have various characteristics about the patients. And so we can then try to distinguish which patients had the higher versus the lower rating of communication.
Yeah, it's always interesting, too. I always recommend that people bring a tape recorder to their visits so they can listen to it later. But if they brought a tape recorder to their visits, then you could listen to the tapes and have an objective, do an objective analysis.
Absolutely, and there are some studies that are doing sort of the recordings and then listening to the style, the way that information is conveyed, whether it's empathetic, empathic. And so what they've shown is that some studies have shown that, first of all, the patients remember different things from what the physician says. So even sometimes if the physician says it, the patient doesn't always remember, or they can disagree on what was said, and that a limited amount of data suggests that providers do, in these sort of audio tapes, they give less information to older women and they give less information to minority women.
Yeah, I think that's right.
So,
they make this statement that they're just not going to be smart enough. Here's another, with lots of questions, so I'm going to move ahead. Was there a link between race and not living with a partner with the delay of initiation for chemo? For example, did you find that the majority of these women not living with a partner were also black women?
So, in just looking at sort of the in a bivariate sort of comparison between black and white women were less likely to be living with a partner. However, we control for that, or that factor was taken into account when we ran the model. So these are independent. So regardless of the relationship between the two, because they weren't highly correlated, that race was independently associated with delay, and living with a partner was associated with living with initiation delay. Yeah. Okay. So meaning that even among white women, the delay was the living with a partner was also important.
Here's a good question from Anne Marie. How important do you believe it is for a newly diagnosed to talk to a survivor patient in a similar demographic with similar diagnosis to bounce their thoughts about treatment? it also relates to, if you don't have a partner, is it more important to have somebody else you can talk to about it?
So the first answer, I would say, I think it's very important. The next thing I would say is I don't think any survivor will do. And I say that because I know of people personally who have made decisions against a recommended therapy based on someone else's experience. And so and I've worked with survivors, we call it Sisters Informing Sisters, where we sort of selected and trained survivors to help be sort of peer coaches for newly diagnosed women. And one of the things that while you share your experience, you have to kind of know and share it in a way that it's not going to influence people in terms of their treatment decisions. And so we remind people that we want them to go back and ask the questions of your provider, and you're not sure about this, and go back and ask. And so I definitely think it's very important to have access to survivors for the support, but I also think just seeing that somebody else has made it been a tremendous value for people that have participated in our Sisters Informing Sisters. But I would say that it needs to be, a survivor who knows where to draw the line in terms of their own experience, and that each person's journey is going to be different.
And Anne-Marie answered, she's right, I was trained to listen first, and commented it's very important for new patients to ask good questions. When we're newly diagnosed, we don't always know what constitutes a good question regarding treatment thoughts. So, again, part of it, I think, is also educating how to get to women who are newly diagnosed with enough education about how to ask good questions in that. And sometimes that does come with having somebody who can come with you, I guess.
Oh, absolutely. And so in our Sisters Informing Sisters, which is another study, we sort of train women, and we tell them to talk back, to tell their story, to ask questions, and to listen actively, to listen and write down when the provider's talking, and then to know their options. And we sort of work them through this sort of decision-making model, if you would, to empower them, because, there's a group of studies out there that show that actually when patients behave a certain way, they can actually influence their physician's behavior by getting what they want, so to speak. And so training women and familiarizing them, with different types of questions, writing down their questions, really what is it. And so we would, when we did that study, we met with women in person. The survivor coach met with them and really worked through what their questions were. And sometimes, for some women, there were other issues that they had to deal with, really practical issues, before they could get to the treatment decision, like maybe telling my family, and so those other psychosocial issues are just as important.
We have several of our advocates saying, first of all, one is Why Me, National Breast Cancer Organization, is a source of trained survivors, and they have a 24-hour hotline. And multiple languages, as I recall, which is a good resource for people who don't have access to navigators or things like that. So it's a good thing to know about. And they also help women come up with good questions to ask their doctors. It's free, and it's on the phone, so you don't even have to have a computer. It's 1-800-221-2141, and I also think it's a great resource for people to know about. Another question, another answer too from a survivor was, I agree it has to be the right survivor. This gives me concern about the way many websites where women post their stories, and as if, that's the answer. Here's a question back to the research. Did you find out, this is from Stephanie, if women who lived with their partners initiated treatment at a higher level due to financial concern, i.e. does a concern about having an additional income during treatment play a role?
So in terms of the initiation of treatment, just the sheer did you have treatment or not, we didn't see that that living status was significant. Where it was important was delaying the treatment. Now in terms of, I think, trying to understand or interpret that, the comment about, or the comment about the financial issues, I definitely think could maybe explain the finding. We didn't measure that or have information about that, but I think that that's something that can help us maybe interpret why it would be important for one group versus the other.
Okay. Was there a correlation, this is from Lynn, between age and likelihood of seeking and following through with treatment?
So we did see that there was a difference between, and we just cut off sort of not younger versus older, but women less than 50 and women older than 50 and older. And so we did see a difference, that age did make a difference, where the women that were over 50 were not initiating therapy at the same rate. And so the reason for that difference, I think, is basically what we'd want to discuss, to say, you know, is it because younger women want, you know, that they're advocating for themselves and they want all the treatment that's available, they're asking more questions? Is it that, you know, is it on the behalf of the provider or the woman? But we definitely did see a difference in age in terms of the initiation or not.
I have a question here. Someone who said that they got interrupted during the talk, but they were, and I don't think we did cover this. What is the occurrence of women in the study who had HER2 overexpressed HER2/neu? Was that more common in the white or the black women, or was it the same?
Actually, it was the same, and we had a low rate of HER2 in the study, and so it was right around 40%. And so it was
40%.
But there weren't. Yeah. Let me see here. Let me just double check.
Well, I mean, it's usually about 20.
Let me see here. Oh, just a second. I'm looking at it. Actually, it was. Yeah. So, yes. And so it was. So it's right around 22%.
Yeah.
But
okay.
it wasn't
so that's about what you would expect, actually.
Right. But it wasn't different between black and white women. And so I think one of the points for us was that we didn't have, in this particular study, we didn't have the higher rate of ER negative, and we didn't have the higher rate of the HER2 negative. So the two groups.
I wonder if it's because you had you had an equal level of socioeconomic level.
Right.
They all had the same access to screening. And screening is going to be more likely to pick up the estrogen positive people.
And so I think that this is.
You have an underserved population that's not getting screened. You may have an overproportion of the estrogen negatives.
Right. And so we didn't see those differences that we expected to find in terms of the tumor characteristics, which, was interesting, so that we really do have a study where the black and white women are much more similar than some other studies that I've been involved in.
Right, but it gives you an ability, when you see differences, then you know that it's really, because of the interaction and those things, because everything else is the same.
Exactly. And
in some ways, it makes the study a lot stronger.
Exactly.
Well, this has been really great. We thank everybody for their questions. We had a great audience. We got one of our Army members saying, "I love having access to these research studies, and I'm also so thankful for the Army of Women and the important service you're providing on so many levels. Thank you so much." And we want to thank Vanessa for giving us the results. As you all know, in the Army of Women, we believe very much that this is a full circle, that we're not just, the people in the Army are not just guinea pigs, we're partners.
That's right.
And we need to participate in both hearing the results and giving our input and questions. And we're getting a lot of thank yous from the participants, and happy Valentine's Day. We will post this on the Army of Women website. So if you have colleagues or friends or members of the Army that you would like to share it with, it will be posted there. And I'm sure we'll be getting more studies from Vanessa to recruit through the Army of Women.
Absolutely. Thank you so much for this opportunity.
Thank you.
and thank you to the Army. This would have been impossible without the Army, so I just thank you so much.
You're very welcome.